Specialty Story, session number 114. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you'll want to practice. This podcast will tell you the stories of specialists from every field to give you the information to make sure you make the most informed decision possible when it comes to choosing your specialty. Now, welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here every week. If you are a pre-med student and don't already listen to the Pre-Med Years, the MCAT podcast, the MCAT Cars podcast, the old Pre-Meds podcast, or any of the other episodes that I have or podcasts that I have for pre-med students, I highly suggest you go check them out at mededmedia.com or premedpodcast.com now that I have that domain as well. Today, I have a great podcast episode for you. I have Dr. Jacqueline Moline on the podcast, an occupational medicine specialist, and we have a great conversation about occupational medicine. Number one, because it's really cool and she was a great guest, but number two, because I have a really big interest in occupational medicine because that's what I did in the Air Force for 5 years. As a former Air Force flight surgeon, what I was doing day in and day out was occupational medicine. Taking care of firefighters, police officers, pilots, air traffic controllers. It's a lot of occupational medicine, as well as the mechanics who work on the planes, the people who paint the planes, and so much more. So I had a great discussion with Dr. Moline all about her job and what she does. We start the conversation by talking about what got her interested in occupational medicine to begin with.
Okay, so I kind of went the long way around it. I did internal medicine for a year because I thought I wanted to be a neurologist. And then I did that 1 year of internal medicine, and I went for my second choice, which was pediatrics. And then when I did pediatrics, I was like, this is challenging enough. I want to do either ICU or emergency medicine. I really like the acute patient. So then I switched to pediatrics. I did 3 years of pediatric residency. And then when I was in residency, I did emergency medicine elective and really got interested in emergency medicine. But I think I was just like overworked, overtired at the time. And I just decided to do pediatrics. And then in retrospect, I thought, well, I probably could have done adult emergency medicine and dealt with the adults. But I don't know. Every time I see an adult, because we see up to age 21, then I have second thoughts. And I'm like, well, I'm glad I did pediatrics because adults they bring it upon themselves with their chronic illnesses.
Yeah, it's a very common sentiment that I hear from physicians who are in pediatrics that the adult world, they just can't get over that. I don't know if it's a bias or a judgment or whatever it is, that it's like, well, yeah, you have liver disease. You're an alcoholic, and like the sympathy kind of leaves at some point. And right or wrong, that's good that you know that, and so you go to something where you don't have those judgments.
Right. So pediatrics, the patients are, usually not manipulative as much as adults. Nowadays they want their MRI, their CAT scan. You do get it from the parents, but they're very wholesome. They are very fresh and happy. And then when you do have a sick kid, it's very challenging and it can be very disheartening if something goes wrong with the child. But I feel like there's more of a chance in changing the child's health care in the future, whereas an adult, it's really hard to make a change, the behavioral change.
Yeah, that makes sense. So I want to go back a little bit. You mentioned starting off doing a prelim year for internal medicine with the thought of going to be a neurologist. Now, my wife's a neurologist, so I understand that path. I want to know the thought process behind what triggered you to go to think that that wasn't the right path.
Well, I didn't realize it until I actually practiced emergency medicine, but I do like instant gratification. And neurology, you don't get that.
Nope.
Maybe for the strokes, but for all the chronic debilitating diseases, there's not a quick fix.
Yeah.
And so I really enjoyed that, like being able to just, do CPR and see the patient get revived, or, you give a bolus and the patient gets hydrated and they look better. So I just felt like maybe it'd be a delayed gratification, but it just wasn't for me.
Yeah. What was it about the intensity that you were looking for, thinking about going into the ICU or some sort of critical care stuff that eventually brought you to the emergency room?
I did look at lifestyle. And so, they say that now ICU doctors have more of a set schedule because they're doing shifts now, like emergency medicine does, but it's not as well defined yet in all hospitals. So the lifestyle was better for emergency medicine. I think that's why, a lot of people are attracted to emergency medicine, because you have shift work, and PICU, you can be on call for 48 hours. You're not necessarily on a shift schedule, but you're on call for a long period of time.
Yeah.
The restrictions went for medical students and residents, but it didn't seem to go for the attendings.
Yes. and that's something I talk a lot about. The students don't really realize. They complain about these work hour restrictions or the lack of them, potentially, depending on how you're looking at it. And I always try to remind them, I'm like, once you become an attending, there's no regulations. You can work as much and as long as they'll let you work.
Right. And you see that with the new faculty, because they want to, get compensated for the time they spend on their charts after the shift's over. And it's hard to explain that.
Yeah. You're like, oh, that's cute.
But I can understand. I was so grateful to get paid extra just for the extra hours we do.
Yeah.
Because that's how it is now. It didn't used to be that way when I first started. I'm sorry my age, but we were told we were salary and you work as many hours and just be glad you have the salary.
Yeah. Get the job
but
done.
It's changed. Mm-hmm.
Yeah. What traits do you think lead to someone being a good pediatric emergency medicine physician?
I always remember this story. We had an applicant not too long ago, and I mentioned to him that he was actually emergency medicine applying for PEM, and I was telling him that I really like ER because I have that adrenaline rush, and I like it when my heart starts beating fast and I may skip a beat. And he told me, well, you can take medication for that. And I was like, but I don't want to take medication for that. I enjoy that adrenaline rush. I enjoy. You have to really enjoy being under stress to do this type of job, which is kind of strange, right? Because a lot of people don't like stress, but you have to be multitasked. You have to be calm during a code situation. You have to be a team player because you're dealing with nurses and respiratory therapists and people that are not physicians. I always say that people that have ADD love the profession because you're constantly getting interrupted.
Yeah, that's true. So I think when I first saw that I was going to talk to you, I saw pediatric emergency medicine and thought, I didn't know that was a thing. And when I went through training, I remember having a pediatric side of our emergency medicine department, but they were pediatricians. They weren't emergency medicine trained, or they were family practice docs as well. What percentage of emergency rooms or emergency departments, rather, do you think have actual trained pediatric emergency medicine physicians?
I think now it's probably about 75%.
Oh, good.
We do have community physicians that are general pediatricians that work at some of our sites, but they're still not able to do the critically ill patients. If a patient needs to be intubated, it has to be somebody subboarded, or the adult emergency medicine physician will take over.
Yeah.
So I think it's going to change so that probably 100%. Because there's not very many. It's a very competitive fellowship. So I think if they open more programs, it'll eventually be probably 95% will be subboarded.
For the future emergency medicine physician listening to this, someone who just thought, I'm going to be an emergency medicine doc, they potentially are hearing about pediatric emergency medicine for the first time, and they're thinking, well, why can't emergency medicine, I should be able to take care of birth to death. Why do we need pediatric emergency medicine physicians? What would you say to him or her?
I've had to justify this because I'm a director of a fellowship, like why we need to the ACGME, why we need more spots. And so basically, they've done a survey looking at emergency medicine physicians, and they actually don't feel like they actually give adequate care for pediatrics because they're not specialized. So, just that in itself is saying something for our profession. And I think that it's, if I did emergency medicine, I think a lot of our emergency medicine residents feel like they need to spend more time in pediatrics because they didn't do pediatric residency. And so they go on and do like neonatology elective or a PICU, another rotation in PICU, or in the emergency department as a sub-I, basically, kind of like, but pretending.
Yeah,
they do that a lot. So I think that pediatrics it's not just a small adult. So there are a lot of things, especially like cardiology, that are different, and just the common bread and butter of pediatrics, they're not exposed to a lot. So I've heard that they always feel like they need more training, the emergency medicine physicians.
Yeah. What types of patients are coming in to be seen by a pediatric emergency medicine physician? Is it typical bread and butter emergency medicine cases? Are there certain pathologies, diseases that are coming in more often than others?
A lot of it's, your upper respiratory infection, your bronchiolitis, your asthma. Mm-hmm. Then, since I work in a academic institution, we have a lot of our subspecialties, such as, the cardiac kids that are hypoplastic hearts, and nephrology patients that are on dialysis. And we have rheumatology, and we have a dysautonomia clinic. So it's different because I do work in the community too, like 1 or 2 shifts a month. So usually in the community, it's your bread and butter. It's your just general, like the same as emergency medicine, but we don't have heart attacks and we don't have strokes. And but you have the diarrhea, the dehydration, the fever workups, the sepsis, and the respiratory. But they usually don't have like multiple medical problems in the community, but you will see them have multiple medical problems when they come to the academic institution, because the parents already know that all the subspecialties are there to round on them. So they know to come there. Like a lot of the heart patients will have like the congenital hearts that have had surgery will have like, maybe they have hypoxic ischemic encephalopathy, and then they have a VP shunt, and then they have seizures. And so they have multiple problems, kind of like a little adult.
For you, what was the decision to be in academics? It sounds like you do spend a little bit of time in the community, and so you kind of have your feet in both worlds. But what keeps you in academics more?
Oh, I just love education, and I do love research, and you can't do that in the community. And so, unfortunately, we are not like adult emergency medicine, where the pay scale is a lot different. If you do academics versus community, it's a lot higher in community. So they always have trouble filling the academic spots. But in pediatrics, basically the pay is the same. So I really don't lose out on any of that. And even if it was a big discrepancy, I probably would still do academics, because I still get like, I get really excited about like teaching, and it's very gratifying to the residents, the fellows, and also doing research.
Yeah.
So I do more clinical research than educational research.
Okay. What does a typical day or a typical week look like for you, if there is one?
Usually, I mean, it's a pretty good, people ask how many days I work, and it's like, well, I work 5, to 7 days, as my kids tell me, teenagers, but they're always like, you're always working. I'm like, no, I'm not. I only go to the ER like maybe 3 times a week. Our shifts vary. They just changed them to 8. So I really like the 12s or the 10s, because I didn't have to go into the ER as often. But I do other things. I do, I work on the fellowship and do schedules and do, talks and presentations. And so I think that I've heard that there's less burnout if you do, a variety of research and education rather than just going to work every day on a shift in the ER. So our schedules, unfortunately, we do 1/3 mornings, 1/3 mids, and 1/3 nights. So we may have all those 3 different types of shifts in one week. And so you may go from a morning to afternoon the next day and then a night the next day, and then have a day to turn around and then go back to a morning. So that's some places do it so that if you have enough faculty, that you do all nights 1 month and you do all days and mids. But unfortunately, if you're we only have like 12 faculty that are PEM subboarded. So it's hard to make the schedule like that.
Yeah. Interesting.
But I try to get all my nights together.
That's good.
Like do 3 or 4 nights in a row and just get them out of the way.
Yeah. Now, I'm assuming as an emergency medicine physician, call for you is non-existent.
Right. We're on backup, but you're not basically on call. You don't have, if they don't call you in, then you're not on call.
What does backup mean? Can you explain that for someone who doesn't know?
If somebody gets sick and they can't do their shift, then you're called in to do it.
Okay. Now, talk a minute. Unfortunately, we live in a day and age where we have frequent mass shootings. In a situation, if that took place in your town, would that be a backup thing too, where they say we just need everyone here?
Right. That would be yes, definitely. Okay. And they do test it out every once in a while. Like they have your cell phone nowadays. We don't have beepers and pagers, so they just put out a group email, a group text saying, this is a test. Call in within the next 5 minutes. We've had a mass shooting. This is just a test, but they just test it out every once in a while.
Okay. Do you feel like you have enough time for life outside of the hospital?
I do. I try to do. I tell people my hobby is my children, and they're going to be going to college in a couple of years. So, I used to be driving all the time, but now one of them is driving, so it's not as bad. But I've always tried to exercise like at least once or twice a week. I may read because it helps me go to sleep, but I really don't have a whole lot of hobbies. Like I talk to these new attendings and they're like mountain climbing. And I love traveling, but I don't consider that a hobby
yeah.
So I do love to travel. So we do make probably one big trip every 2 years.
Good.
Like to Europe or, South America, or it just gets expensive, but
yeah. Yes, it does.
But it's worth it. It's really nice to get away.
Yeah. So what does the training path look like to become a pediatric emergency medicine physician?
For adult emergency medicine, you do a residency. Some of those programs are 4 years, and then some of those emergency medicine programs are 3 years. And for fellowship, for them, in our program, it's only 2 extra years of fellowship. But in some programs, it's 3 extra years, even if you did emergency medicine. For pediatrics, you do 3 years of pediatric residency, and then you're required by the American Academy of Pediatrics to do 3 years of fellowship.
Interesting. So there's 2 routes into pediatric emergency medicine, either through
emergency medicine.
Yeah, pediatric emergency medicine, or pediatrics. Very cool. Okay. Mm-hmm. And then they're both fellowship training after that.
Right.
Okay.
Unfortunately, it's gone down in the number of emergency medicine residents that apply. Most of them are pediatric residents.
Why do you think that is?
I think it's because in emergency medicine, your salary can be, pretty good after getting out of residency. Mm-hmm. So they don't really want to go and do more training because they want to pay off their loans. Yeah. Whereas in pediatrics, I think I think that they probably don't get it. The people that really like excitement and ICU and there's a lot more of, them that were willing to spend 3 extra years.
Yeah. I mean, it may be
Because
potentially
the pay's not as good for
Yeah.
general pediatrics.
Yeah. And unfortunately, the decision of specialty, which shouldn't be based on pay, oftentimes is just because of the debt load nowadays.
Correct. It is. They're very mature, the residents getting out about how they're going to pay back their loans.
Yeah. And it sounds like potentially you have people who are self-selecting into kind of a high intensity specialty right away, the emergency medicine physicians. And so maybe they don't need that extra training, or they don't want that extra training. And then you have those who didn't potentially know that they were interested in high intensity training, the pediatric residents who are like, yeah, I think I do want something more. And then they take that extra training.
Right. Exactly. That's exactly true. Because most of the pediatric residents, like 75% of them, go into just general peds, which is clinic.
Yeah.
And you're not going to see any intensity, and they really will miss out on that.
Yeah. For someone who doesn't want to do procedures, doesn't like to do procedures, is emergency medicine a good path for them?
I don't think so. I think, if people get really scared with stress or don't like to do procedures, I don't think it's probably a good profession. And ultrasound has become so prevalent now, and it's procedure. And so we do it it's required for all central lines. So you're going to have to like to do procedures.
Yeah.
I really do believe you do.
Okay. What is you mentioned you're the fellowship director there for let's say a pediatric resident who may be listening to this, who wants to go into emergency medicine. What should he or she be doing to make themselves competitive to match into a fellowship?
If they are not associated, their medical school is not associated with emergency medicine department. There still are some out there that don't have pediatric emergency medicine subboarded people working there, then rotate to an emergency room. It could be far away even, but a large ER that does have several, even a freestanding children's hospital that have, PEM subboarded physicians, because you do need to get letters of recommendation for one. And it's better if you get letters from a PEM subboarded person than just like a pediatric, attending. Like to see letters from at least one PEM subboarded person. And then, so do away rotations, if possible, even if you do have a PEM, pediatric emergency medicine department in your hospital, just because it improves your chances, because you get to get a letter of maybe recommendation from them also. And it helps expose yourself and helps show that, you're a good worker, and the department, I'm sure, will look highly upon that, because I know we do. Yeah. Also, research is a big part of your application. Unfortunately, they like to see, I'm a little different because I'm kind of unbiased, but I know a lot of programs want, to see an applicant be first author on a case series or a case report. Those are easier to get for medical students. So I'd recommend trying to do at least a case. It doesn't have to be emergency medicine, but in anything, they look for any scholarly activity. Grants. Grants aren't expected, but it always looks great if you did get a grant.
Yeah. For the osteopathic medical student listening to this, what does he or she need to do to overcome any potential negative bias towards them?
Fortunately, I've been in programs where there wasn't a negative bias towards them. So I really can't give any advice other than get a lot of research, on your resume, or even, regional talks that you've given, lectures, just scholarly activity that's been disseminated on your CV. Like medical school, they wanted you to see, how much volunteer work and all that. But for fellowship, it's more so scholarly activity. And then also, if you're be a a member or even an officer on some of these, you know, academic committees, that really helps. And I've seen that where a lot of times medical students get on the quality committee for the hospital. So I think that would apply for, DOs and MDs.
Okay. What do you wish the pediatricians knew about pediatric emergency medicine to potentially help their patients and help you do a better job?
I didn't realize nowadays pediatricians don't have a lab or x-rays in their clinic. So they do send their patients quite often for those services. You hear in the news that, people are using their ER as their clinic, and people are just wanting things done quickly. They don't have as much patience. So they come to the ER because they don't want to wait to see their doctor in the morning. But it depends on their copay too, right? Because, and then urgent cares have become so popular now. The copay is so much less, the parents will tell me, than coming to the ER. But for pediatricians, they know that we can do, most of them know that we can do all those services, but maybe some of them don't. And a lot of them don't know, that we do have a nephrologist, we do have a cardiologist, we do have dental. So a lot of it is they do call us on our Spectral links all the time, just asking our opinion or asking us if we have these services, or do they think that we should have them patient transferred in. And so it does help them know more or less where, if they don't feel comfortable to send them in, it's better. We don't have telemedicine at our hospital yet, but that's the new way of doing things, is they can actually see the patient and kind of decide whether or not they need to come in right now versus later.
Yeah. Are there any special opportunities outside of clinical medicine for pediatric emergency medicine physicians?
I had a medical student one time talk to me, and they said, I've thought about emergency medicine, but when you get older, you're not able to just go work in the ER the rest of your life. You can't go to a clinic like a pediatrician can. I could potentially work in a clinic, if you break your hip or do something, but you can't be walking around the ER with a broken hip. You have to act quickly. So, she really had looked at the ins and outs of when she would, get up there in years, what am I going to do? Am I going to go work in urgent care? And that's one thing that is different, is if you go into pediatrics, you'll be able, emergency medicine, you could go into a purely academic role. If you go to medical school, you could work as a pediatrician in urgent care. You could work as a general pediatrician. Whereas for emergency medicine, it's harder because a lot of them try to go into physical medicine or ultrasound or something where it won't be so stressful on their body.
Yeah. What do you like the most about being a pediatric emergency medicine physician?
Oh, I still like the action. Everybody kept telling me that, I'd be going out to the community in a few years. I'm over 40 and over 50. So they say, oh, you're going to be just, wanting to go into the community and see the coughs and colds and never have any action. But I still like the action. I still like doing CPR. I still enjoy procedures. I still enjoy, I think I do most of my teaching on those subjects, on resuscitation. I do mock codes. I do a lot of simulation in the simulation center for procedures, for mock codes. So I still enjoy that, and I don't think I'd probably be fulfilled if I didn't have that one code a month or a week. It'd be unfulfilling to me.
Yeah. What do you like the least?
I do like the resuscitations, but if it goes bad, then it's the telling the family that their loved one has died. That's just really hard. There's a lot of drama behind every illness in the emergency room, and so you're going to have to be used to spending time with the family. And even though you may have to go back to the ER and take care of other patients, you have to really spend time with them and letting them know what happened to their loved one.
Do you see any major changes coming to pediatric emergency medicine that someone should be aware of?
Not right now. I mean, I just feel like we have to be more cost effective because of the cost of emergency medicine care. But luckily, I was taught by a Canadian. And so I was taught, I think, anything I try to teach the residents, don't just order a bunch of labs, go see the patient and really decide what you need to order, because that's what's killing us nowadays with the cost of healthcare, is just ordering too many things.
So let me ask you a question about that, because when I was in my training, it seemed like the hospital loved the emergency medicine docs who ordered a ton of stuff because that was revenue for the hospital. Do you see a potential pushback from administration, from the hospital, to say, why aren't you doing more labs? You're behind compared to your other colleagues?
Yes, it does, and especially in the community. Luckily, in the academic institution, I don't think it counts as much because you're not RVU based.
Yeah.
But I still believe you have to practice good medicine, and it doesn't mean ordering all those tests. It's just it's hard on the patient. It's hard on the government.
I agree.
So I didn't train in Canada, but I trained under a residency program director who was Canadian. So he didn't let us order anything until we asked him. And we justified it with literature.
Yeah, that's awesome. If you had to do it all over again, would you still be a pediatric emergency medicine physician?
Yes, I would.
Any last words of wisdom for the maybe future pediatrician who now is like, oh, this emergency medicine thing sounds kind of cool, or for someone else who wants to explore this a little bit more?
I think it's a great life. It's very gratifying. It's very diverse population. It's exciting. It's something that you'll always appreciate, and you'll never get bored.
All right, so there you have it. Now you know everything about occupational medicine, and hopefully we can reduce the number of students who don't know anything about occupational medicine, at least by a little bit. Go share this episode with your classmates. Let them know that there is this amazing specialty out there that has tons of opportunities for life outside of medicine as well, at least life outside of clinical medicine. And Dr. Moline shared a lot of those opportunities as well. So if you're in for an adventure, if you like variety, if you like the detective work that Dr. House does on his TV show of going and really exploring what could be causing someone to be ill, occupational medicine is an amazing specialty that you should check out. So I hope you go and check it out. I hope this opened your eyes to the specialty, and hopefully we get some more occupational medicine physicians out there, because we need more of you. So I hope this was helpful for you. I hope you have a great week. We'll see you next time here on Specialty Stories.
This is MedEd Media.